Welcome to this detailed explanation on managing the side effects of cancer therapy. This is an absolutely critical topic for the PEBC MCQ exam. So we're going to break down some of the most complex and high-yield toxicities you need to know.
Okay, let's dive into our roadmap for today. We're going to build your clinical mastery from the ground up, starting with foundational principles, then getting into the specifics of radiation and drug toxicities, and we'll wrap it all up with a review of key management agents.
So first things first, we're going to set the stage with the fundamental concepts that govern how we even approach cancer therapy toxicities. Understanding the why is key. It's absolutely crucial to understand the timeline of side effects. We manage early things like mucositis or nausea right there during treatment. But those delayed effects, like secondary cancers or heart failure, well, they require long-term surveillance, especially as our patients are living longer and longer after cancer. So this whole early versus delayed distinction, it guides our entire monitoring plan. And this right here brilliantly illustrates the core difference between our two main therapies. It's local versus systemic. Think of radiation like a laser beam. The damage is pretty much confined to the beam's path. So chest effects for lung cancer, right? But chemotherapy, that's systemic. It affects rapidly dividing cells everywhere, from your bone marrow to your hair follicles. And that's what really dictates the side effects we need to anticipate. These are really our guiding principles, our ultimate goals. The whole point isn't just to react to a side effect after it happens. We want to be proactive. We want to maintain that quality of life. And maybe most importantly, make sure our patients can actually complete their full, potentially curative treatment course. All right, let's get into our first deep dive. We're focusing on two really critical systems that get hit by radiation: the blood and the bones. This is where side effects can be both acute and have some profoundly delayed consequences. This question gets right to the heart of a really important concept. Even though radiation is local, right? When you start irradiating areas that are super rich in bone marrow, like the pelvis, you can absolutely cause systemic effects. And yep, myelosuppression is the big one. When you irradiate a large volume of bone marrow, like what you find in the pelvis, you're going to see drops in white cells, red cells, and platelets. The management principles here, things like growth factors and supportive care, are actually very similar to what we use for chemotherapy. Now, for this one, osteoradionecrosis, prevention isn't just important, it is everything. This is a truly devastating complication, where the irradiated jawbone literally dies and becomes exposed. And since managing it is so incredibly difficult, we're talking debridement, antibiotics, sometimes even resection of the jaw. Proactive dental care is paramount. Any problematic teeth must be extracted before that head and neck radiation begins. It's a very similar story with trismus-DA. That's the inability to fully open your mouth. Again, prevention through physical therapy is just way more effective than trying to treat it after the fact. Once those jaw muscles fibrose from the radiation, it is incredibly hard to reverse. So proactive stretching is absolutely essential. Okay, let's shift our focus now to the genitourinary system. This is another area that's highly susceptible to damage, especially when radiation is aimed at the pelvis for cancers like prostate, cervical, or rectal cancer. So when we're managing these issues, a lot of it comes down to ruling out an infection first, and then using some pretty familiar drugs. For that frequency and urgency, you're thinking oxybutynin or tamsulosin. And for the more serious hemorrhagic cystitis, the approach is really similar to drug-induced cases: hydration and maybe even bladder irrigation. Now, this is absolutely critical. When it comes to reproductive toxicities, you have to be proactive. Those conversations about fertility preservation, like sperm or egg banking, they have to happen before treatment starts. Then, for functional issues that pop up after treatment, we've got tools like PDE5 inhibitors for erectile dysfunction or vaginal dilation. All right, moving on, let's talk about the lungs and the central nervous system. These are areas where radiation side effects can have some really profound long-term consequences. Okay, radiation pneumonitis. This is basically an inflammatory reaction in the irradiated lung tissue. If there's one thing you remember for your exam about this, it's corticosteroids. That is the cornerstone of management. If a patient comes in with a dry cough and shortness of breath a few months after chest radiation, your brain should immediately scream pneumonitis. And the go-to treatment is a course of prednisone. Here's another super important one to file away: the potential preventative role of memantine for cognitive decline after whole brain radiation. And just as critical is the use of dexamethasone for cerebral edema. I mean, radiation-induced brain swelling can be life-threatening, and high-dose dexamethasone is the absolute standard of care. So let's wrap this section up with two other key toxicities to keep on your radar. First, the long-term risk of secondary cancers, which just means regular screening is a must. And second, that acute pain flare you can get from bone irradiation, which importantly can be prevented with a short prophylactic course of dexamethasone. Okay, big shift here. We're moving from the localized effects of radiation to the systemic, body-wide side effects of pharmacologic agents. This is where we go from the beam's path to affecting the entire body. Let's talk about the heart. Cardiotoxicity is a major dose-limiting concern that can show up years after treatment is done. So let's break down two key examples where lifelong vigilance is an absolute must. When you hear anthracyclines like doxorubicin, your brain should immediately go to cumulative cardiotoxicity. The key point here is that it's often irreversible. That's exactly why we strictly track those lifetime doses. And for patients who absolutely have to go beyond those limits, we can use the cardioprotectant dexrazoxane, or maybe some less cardiotoxic liposomal formulation. Okay, pay close attention to this one because it's a classic mix-up on exams. Hand-foot syndrome and hand-foot skin reaction, they are not the same thing. HFS, which you get from classic chemo like capecitabine, involves more diffuse swelling and peeling. HFSR, on the other hand, comes from targeted agents like sorafenib and is really characterized by hyperkeratosis, that's a thickening of the skin, over pressure points. The underlying mechanism and the drugs that cause them are different. You can't just throw one thing at hemorrhagic cystitis from ifosfamide. It really requires a three-pronged approach. It's not just about giving Mesna to neutralize the toxic metabolite, acrolein. We also need aggressive hydration to flush it all out. And we try to give the chemo early in the day to minimize that overnight contact with the bladder. All right, for our last section, let's pull everything together into a rapid-fire review of the essential drugs in the pharmacist's toolkit. Think of this as your high-yield cheat sheet for managing these side effects. Okay, neutropenia. G-CSFs are our go-to. But here's the clinical pearl, the thing that always gets tested, the timing. You have to wait at least 24 hours after chemotherapy to give G-CSF. If you give it too close to the chemo, you can actually make the neutropenia worse by stimulating young cells that then just get killed by the chemo. This is a classic exam topic. You absolutely have to know the high-dose loperamide protocol. For standard chemo-induced diarrhea, yeah, the usual max of 16 milligrams per day applies. But for the severe, delayed-onset diarrhea caused by irinotecan, which can be life-threatening, we throw that standard max dose right out the window and use a scheduled high-dose regimen of 2 milligrams every 2 hours. So what's our special tool for anthracycline cardiotoxicity? It's dexrazoxane. It's an iron chelator that we use pretty selectively in patients, often those with metastatic breast cancer who are about to exceed their cumulative doxorubicin dose limit. We don't use it for everyone because there's still a lingering concern that it might reduce the chemo's efficacy. Remember Mesna. It is the absolute must-have antidote for preventing hemorrhagic cystitis from ifosfamide. It concentrates right in the bladder to neutralize that toxic metabolite, acrolein. And remember, it's mandatory with every single ifosfamide dose, and there are a bunch of different IV and oral dosing protocols out there. Okay, tumor lysis syndrome. It really comes down to knowing the difference in mechanism, because that dictates how we use these drugs. Allopurinol prevents the formation of new uric acid, which makes it great for prophylaxis. Rasburicase, on the other hand, breaks down existing uric acid, making it perfect for treatment. And please, do not forget the critical contraindication for rasburicase, G6PD deficiency. And that brings us to the end of our structured review. As you get ready for your exam, just remember the pharmacist's role is really shifting from reactive to proactive. Mastering the principles we've talked about today, from pre-treatment dental screens for radiation to knowing the cumulative dose limits for chemotherapy, that's how you show you can make treatment safer and more tolerable for patients. It's that proactive mindset that's really going to be tested. Thanks for joining this explainer.